you know, this is a smaller group, and so I like to just know a little bit about the ages and of all the kids.
They're trying to come here.
Oh, fantastic. Oh,
They're
I
trying
think
to get
I've
a
heard
schedule.
of that.
They're having trouble getting a joint.
Yeah, with them both at the same time. Okay. Well, I think Susan is here, who's our clinic coordinator. Not in this room, but she's here at the conference, and she's trying to get it coordinated to be able to get. You guys are from the East Coast somewhere, I think. Is that right? Yeah. Tennessee. Okay.
Yeah, we had an appointment and it got postponed, and then
Okay.
so we're trying to get
Another one. Okay. So let's work with Susan and see if we can do that. And then if everyone else can just tell me the ages of your sons, that would be great. I know there's some.
Yeah.
8.
Kyle 9.
Yeah. Oh my God. I met Kyle when we were little.
13.
Okay. Okay. Wow. Okay. And then how old is that now?
13.
Yes.
What's turn?
So we're going to talk about medical problems and medical follow-up in XYY. I know a lot of people have questions about behavioral and emotional difficulties as well, and we will try to cover that. They asked me to cover these medical things, which I think are important also, but I'll throw in some of the behavior and development pieces also. So this information comes from a research study that we did in 2 places between 2004 and 2009, starting at the University of California Davis Mind Institute in Sacramento, where I met many of you, and then also at University of Colorado at the Children's Hospital, where I am now. We have 43 males in our group with XYY, and their ages range anywhere from 6 months to 38 years, with the average age is 12.5. We know that XYY has a big variation. You know, it happens in 1 in 1,000 males. We diagnose less than 10% of it in, you know, in the when we actually look at how many we diagnose as medical professionals. So we're missing a lot of kids and adults with XYY who are out there. However, so the ones we tend to diagnose, if they're not diagnosed in the prenatal period, the ones who are diagnosed tend to be ones who may be having more developmental or behavioral difficulties. So doctors are sending genetic testing for those problems. I'm a developmental behavioral pediatrician. That's my specialty, is in dealing with developmental behavioral differences. So the people who come to see me are coming to me oftentimes with those concerns and with those areas of concern. So our sample that we have of these 43 males is not representative of the whole entire spectrum that could ever occur, but it's more representative, it's more skewed toward the kids who are having problems. And I don't think that's a bad thing, because the kids who are having problems are the ones who need our help, and that's what people are coming to see us for. But when we report on percentages, some people have a child or baby who, you know, is just newly diagnosed, and it doesn't mean, you know, necessarily that your child's going to have all those problems that we're talking about. But these are, you know, most of the time the people who are coming here are the ones whose kids are struggling a little bit in different areas. And so, you know, and that's our job, is to help address those things. And so there is a lot of bias in our sample towards those kids who are having more problems. And I always think it's important to kind of talk about that at the beginning. Okay, so in our group we had 15 who were diagnosed in the prenatal period, or 34% were actually diagnosed in the prenatal period. And then another 8 who were diagnosed between 8 months and 3 years because of low muscle tone and developmental delays. We had 14 who were diagnosed because of various behavioral problems like ADHD or mood instability or other behavioral difficulties. 3 who were diagnosed because they had an autism spectrum disorder, and then somebody tested them. And then 3 who were diagnosed because of dysmorphic features, differences in the way they looked. But when we looked, 2 of those kids actually had other genetic syndromes. And so we found one other child who had XYY, something called Angelman syndrome. We have another child who has XYY and a distal 22q deletion. So in general, those are associated with more significant medical problems and cognitive problems, those 2 problems. And so those kids I kind of took out because we can't sort out, you know, what is XYY and what are the other problems. Did you have a question?
Yeah, I understand how prenatal and even the developmental disorders kind of confusing, but why did they test autism spectrum disorders for genetic?
Because in all of autism, there are anywhere from 10 to 20% that are caused by a genetic disorder. So the standard medical recommendations for a child who has a new diagnosis of an autism have a medical genetic evaluation to see if their autism comes from one of those genetic problems that we know is related to leading to differences in the brain development. So they test usually for Fragile X syndrome, which some of you guys may have heard about, and we test chromosomes for chromosome abnormalities. If you do screenings of, here's 100 kids we tested with autism, and there's lots of studies that do this, there's always 1 or 2 in there with XYY. So, in big screening studies for kids with autism, 1%, 2%, have XYY or an X and Y variation, but usually it's XYY or XXYY. So we think that there's higher rates of autism spectrum disorders in XYY, and I can show you some of that information. If they were diagnosed after birth, and this I think is a little bit disheartening because, there's a lot of these guys who were actually diagnosed late in life. So after birth, if we kind of pair it up into, those kids who were diagnosed after birth, we have a quarter of them who were diagnosed less than age 2, a quarter of them between 3 and 5, another quarter of them between 5 and 10, and another quarter of them after 10. And, I would like to see this all a lot earlier because we really want them to be able to be getting early intervention therapies for parents to understand what's going on with the kids and why they may be struggling in different areas. And so it's really sad when you hear about the, 14-year-old who went to a different doctor and someone said, well, hasn't anyone ever talked to you about genetic testing? And then they get diagnosed at that point. And so I don't know if any of you guys ever went through that, but we see a lot of families who had many, many years of not understanding what was not quite right or what was different about their kids. So we're going to talk about these things. We're going to talk a little bit about growth. We're going to talk about bones and joints. We're going to talk about acne. We're going to talk about tics and tremors, seizures, motor tone coordination, puberty, testosterone and fertility, and then other medical problems. So these are all, a lot of people will tell you about XYY, and all you hear is, well, they're going to be tall, and then you hear about they might have behavior problems, and then you don't really hear anything else. So there are other things that are associated, and I think it's important for everyone to know about them. They're not severe medical problems, but, sometimes they can be more significant. So growth in XYY, and some of you guys have heard this talk before, and I've added in some new things, but some things really haven't changed. They're still tall in the same way that they were tall last year. So, there's some things I apologize for people who have heard me do this spiel 20 times before. But tall stature is definitely one of the things everyone talks about, and it is a feature of XYY. We tend to see the stature increase as they get older. So babies are not necessarily these tall babies. But, as they get older and older, then that height above the 50th percentile increases. It's also not always, not everyone with XYY is super tall. Some of them are just tall in comparison to their family. So if you have mom who's 5'2" and dad who's 5'6", the boy who's 5'11" isn't tall in the general population. I mean, he's kind of tall, but he's tall compared to the family history. So it tends, there's a lot of other factors that influence growth as well. In the literature, the mean height is 6 feet 3 inches. And in our group, we didn't have a big group that were over age 17. We have a lot of kids that we're following, but they're not over age 17. But in our group, our mean height over age 17 was actually 73 inches. So that's a typo in there. 63 inches would be 5'3", but 73, they were actually 6 feet. So it was about the same. So the average height in the adults is about 6 feet, which is tall. And they were taller than their fathers by 4 to 6 inches. So, that was more significant. If you have other tall genes in your family, then you're also more likely to be taller. And then puberty may be slightly delayed. This, again, we don't have great studies, but from the literature, the puberties tended to start a little bit later at 13.8 years versus 12.4 years in the male siblings. But some kids actually reported early puberty. So, some are early, some may be late, most are normal. We don't really know that much yet. The growth spurt tended to start later but lasted longer than their siblings. And so if they had a brother, it started a little later, but then they grew for a longer amount of time after. So everyone asks, well, why are they so tall? And there's a couple reasons we know why XYY guys are tall. So the first one is that this is generally why there's differences in XYY just in general. But so this is a typical XY male. You have a normal X and a normal Y. And there's certain genes that are repeated on both chromosomes that are the same. is on the X and the Y. And it's related to height, it's related to cartilage growth and bone growth. And so in XYY, you have 3 copies of that. And so that is, you end up having higher expression of the SHOX gene. And so, do you need me to wear anything, Dan? Okay, I accidentally stole your other one and then I gave it back. Okay. And so you have 3 copies. So then you have overexpression. And that, we think, is what's responsible for tall stature. However, there's also something else. It's called the GSY, which is really a really non-specific, no one knows where this gene is, but it's this proposed growth gene on the Y chromosome that just explains in general why guys are taller than girls. And so we also think that boys with XYY then have 2 copies of this. So they have extra SHOX, they have 2 copies of this GSY, and so they tend to be taller. And we also know that if you compare XXY, where they only have 1 X, but they would also have 3 copies of SHOX, XXY guys are actually shorter on average than XYY. So if you look, it's XY, then XXY, then XY, and then our XXYY guys are even taller. And so they have 4 copies, and so, it's making them even taller. So we think that's, why they're so tall. And I introduced this with growth because this is really the idea of why we think there's differences in all of them. Why is there growth? Why are there differences in brain development? Why are there differences in other, aspects of motor skills and other things in XYY? It's because there's genes that are expressed differently compared to XY boys. And so we don't know what those genes are yet, but, are those genes things that are related to speech development, to learning, to emotional regulation, social skills? And so we think that, some of the differences in the way the brain development is because there's, differences in the gene expression in their brains while they're developing. So, we know this is true in which genes are involved in growth, but we don't know what it is involved in brain development. But it's the same idea, that there's something, dysregulated. They're a little different about the way their genes have developed. Okay, so here we're going to talk about bones and joints, and I don't know if these legs look familiar to any of you. Some people will be like, I see, those are my son's legs. There are no one's son's legs in this room, but they sometimes see it. And so we can see low muscle tone, we can see flat feet, we can see knock knees, joint laxity, hyperextensibility in the joint in XYY. And so what that ends up looking like when they're younger is often this look where they have knock knees, they have flat feet, their ankles go in a little bit. This can sometimes be controversial in terms of the treatment. Some people will say, just go and as long as it's not bugging them, it doesn't matter if they have flat feet. And other people will say, well, you always have to do braces and arch supports and other things. I'm kind of in the middle. I mean, I don't think kids, you already are struggling with enough stuff. You don't need to put arch supports and try and get them in all their shoes or have braces on their ankles for a little bit of a problem. But if it's causing them pain, if you're seeing it's impacting their motor development, if the physical therapist is recommending it, then, clearly I think it's important to do it. So, I don't think every boy with XYY needs arch supports or braces in their ankles, but some of them do and benefit from it. And this is usually when they're younger. When they're older, they might, they might like having arch supports in their shoes, but they'll tell you that and then they'll wear them. If it's a fight to get them to wear them and you don't see any benefit, then, I don't know that you have to do that fight. And sometimes you have a few more to do.
Ask a question.
Yeah.
2 things. One is, if their ankles are turning in, are there consequences in terms of how that's going to affect their
bone growth and knees?
Yeah.
Yes, if it's significant.
Okay.
If their ankles are actually turning in, like if you, I don't have it on this one, but if you can see this little boy, his ankle is turning in, like you can see that. If he's walking on that inside of his foot for long amounts of time, that's going to cause problems. He has braces for his feet. And so, but if it's a little bit of flat-footedness and dad is flat-footed and, then it's not, it doesn't necessarily mean you have to put braces on or arch supports in.
The other question is, like on our son, we noticed that his toes are really crooked.
Mm-hmm.
Is that a result of feet turning in, or is that something you see?
I don't know about toe consequences from flat feet. I haven't heard of that.
Okay.
It can also just be that they're toe, but yeah.
I asked, because my son has flat feet and his toes grow under.
Yeah.
And I asked the doctor about that because I was concerned. They recommended, he's got arch supports and he demands them in all his shoes. but it's pain. But the toe thing, you said that has nothing.
Well, sometimes kids will grip. Like
Yeah.
if they have poor balance and they're not, you know, then they start to grip with their toes.
Yeah,
And so you
because
can see it that way. Yeah.
You said that the shoes sometimes will make them curl under.
Yeah. There's not a lot of science. You could ask 10 different orthopedic surgeons and
Yeah.
PTs and they'll give you 10 different answers. But my main criteria are if there's pain, if you're seeing it's impacting them, if they're not wanting to do physical activity, you know, then clearly see what you can do to help them.
So just crooked toes and no massage and nothing to be concerned about.
No. Crooked toes usually mean you have a great mom.
There you go.
I can use that answer a lot, because there's a lot about XYY we don't know. Okay, so but other things about the elbow. So do any of your boys have funny elbows or elbow problems? So one of the main things we see in XYY that are related to the, so they can be hyperextensible in their elbows, they can have really prominent elbows, and they can also have some actually limited range of motion in their elbows. And sometimes it's due to something called radial ulnar synostosis. So this is a normal elbow. This is your humerus. These are the two bones in your forearm. This is your elbow joint here. And you can see on this boy, who has, actually this was a boy with XYY, his two bones are fused. And what that does is that limits your supination and your pronation, this movement in your arm.
Is that what it looks like for left hand?
And so, yeah, for him, he has it on both sides, actually. But he can't go further. That's all he can do. He can't get all the way flat. So if you fix the shoulder and you do this is an isolated movement, he has no movement there. Now that's important to recognize, right? Because the physical therapist is saying, well, just, do this, and the OT is trying to work with him to move his arm around. And you can do a lot of movements because you compensate with your shoulders and your wrists. But there's still some things, like when he carries his books, he can't quite carry them right. And so he's needed some accommodations at school for this in terms of how his desk is situated, a book bag instead of having to carry these books and, feel awkward and clumsy with it. And so, most of the time there's nothing you do about it. But I think it's important to know about it in terms of therapy and helping with some adaptations. Yes?
Is that why his hands are being held slightly differently? You see the thumbs and...
Yeah.
So there's more volume.
So he can't do, one side is more effective than the other. So he's kind of doing as much as he can, and that's limiting the range of motion.
And surgery can't correct that?
Surgery can correct it, but a lot of times it doesn't always correct it fully, and that's a big risk if it doesn't work well. They used to do some surgery to correct it, but then there's pain and there's more higher risk of arthritis and other problems later on. So if it's significantly deformed, now there's some kids where it was a huge cosmetic problem because in some kids it can really be dislocated and all this stuff too. So he had surgery to correct it and he was happy with it. Another teenager had surgery to correct it because he was more involved in sports, and it ended up being worse afterwards because it just didn't, So there's usually no treatment for it, but recognition of it is important to adapt skills and adapt different things. So acne is something kind of one of those myths. I get a lot of myths about XYY. And acne is one of the, well, don't they get more acne? Don't they have higher testosterone? This is something that some of the genetics reports show. And so from the 1970s, there's 4 reports of what's called nodular cystic acne, or pretty cystic significant acne in XYY. In our sample, we had 2 of 15 so we only counted the adolescents and adults, but 2 of the 15 had mild to moderate acne. There were none with severe cystic acne. I don't think 13% is different than what we would see in the general teenager population. So I haven't seen this, crazy skin problems acne related to XYY. However, in any, I do this for a general pediatric audience too. If you see acne, it can really impact you socially. And so I think it's important to treat. There's tons of treatments that are out there now, lots of antibiotics, lots of different skin treatments. So going to the dermatologist and taking care of it and not being embarrassed to address it with the kids or saying things like, oh, well, it's just a part of growing up, or my favorite one, just God's way of slowing you down a little, dear. Just help them. A lot of people have enough social difficulties as it is. They don't need to also deal with acne. And so, just go to the dermatologist and get it Ticks are another thing that were reported in the literature and really we've seen pretty frequently in our kids. Do any of the boys in here, or your kids have ticks, motor ticks? What?
You know, Brandon went through a period where he was doing this head thing, and then it stopped.
Okay.
So is that?
It might have been a tick. So typically, motor ticks are either blinking, shrugging, kind of funny head things, and you see them in the general population in about 10% of kids. And they usually show up at 5 or 6 or 7, and then they go away 10, 11, even before that. So they can wax and wane in intensity, and that's just a typical tick, you know, and it's not uncommon to see, and they usually don't need treatment and anything else. So that might have been what he had. It's like a dopamine response, and you know, you can see them increase with anxiety, you know, so kids get more when they're anxious, and then most of the time they go away, but what we've seen is more persistent ticks. And when you see persistent ticks over 6 months of duration, it's considered a tick disorder. And it doesn't need to be treated all the time, but it sometimes needs to be treated, and I think it needs to be treated if it's causing them social, any kind of social consequences. Again, like the acne. There was one boy with XYY who was nicknamed Twitch at school. And he was 16, and they called him Twitch because he had all these ticks. And his parents didn't want to start him on medications because, well, that's a medication, you know? And so, you know, if they're calling you Twitch at school, clearly your self-esteem is going to be impacted, and it's impacting you socially, and everyone else is noticing. And so then that's a time, you know, you clearly want to treat. So if there's any concern, if the kids bring up concerns, them being made fun of, if it's, I mean, you know, if you're seeing them increase a lot with anxiety, then I think it's a time that it needs to be treated.
What's it usually treated with?
There's 2 different classes of treatment. There's one that actually targets the tick itself. Some of those medications are clonidine or 10X. If it's really bad, there's one called Risperdal. And so those can actually be, they target that dopamine system. The other treatment is that a lot of times it increases with anxiety. And so you only see them when they're in more anxious situations. And then if you target the anxiety, you actually see the ticks go down. Or they're only showing up when they're in more anxious, you know. They're not showing up as much because there's not as much anxiety. So it just lessens the time that you see them. So, but in our study, we had 41% who had ticks. Now we don't have a tracking of who's went away. So I don't know if Brandon is in this, you know, 41%, but we don't know who's exactly went away. So that'll be important. And we talk about this. The other thing that's really important is that a lot of guys with XYY have ADHD, and tics can be exacerbated by ADHD medication. And so most of the time in ADHD, if you are treating them with ADHD meds and they start to have tics, with continued ADHD treatment, those tics will improve. Sometimes, but rarely, we have to actually stop the ADHD treatment because the tics persist, and you know that's just not working for the kid to be paying attention but having lots of tics. So, we've had a couple boys with XYY who've had actual diagnosis of Tourette syndrome, which is motor tics and vocal tics. And you know, it's not usually the kind of layman's press, you know, version of Tourette's where they're screaming out obscenities, but vocal tics are often throat clearing or little clicking noises or different noises that they make. And so any combination of those 2 can be, if you have motor and vocal tics for greater than 6 months, it's considered Tourette syndrome. But Tourette's is also often associated with ADHD symptoms, which we see a lot, and sometimes with obsessive compulsive types of symptoms as well. Yeah?
You know, while you were talking about that, my son he still does to an extent, but it used to be very, very severe about going while he was talking. Would that be? I always thought it was a speech problem, and the therapist said, no, it's not a stuttering, and to me it was.
Yeah.
Is it more like a tic?
Sometimes it can be a tic. Little sounds that they make, especially, like we had one boy with XYY who, in the middle of sentence, knock, knock, and then he would start talking, knock, knock, and he would put these little words into the middle of sentences, and you can see it a lot more frequently as it got more anxious, and then, you know, you didn't see it all the time, and so that was a vocal tic.
Oh, okay. That explains a lot.
Yeah. So tremor, did any of the boys in here have any problems with tremors in their hands? Okay. So this is something else, you know, I don't think this was really well recognized in the older literature of how common this is. And I think this is something important. The reason I think it's important is because we miss so many kids with XYY, and we don't usually see tremor in kids. And so, you know, if a neurologist, it's usually actually not severe tremor that's causing all these problems, but their hands are shaking. And so, this should be a clue to pediatricians or to neurologists. Wow, we need to do some, some genetic testing on this. Are there other features of XYY here? And so we actually just had a patient who was diagnosed in our hospital from, he was in the psychiatric ward having all these horrible mental health problems, and then they noticed a tremor, so they sent him to the neurologist, and the neurologist was like, oh, well, I don't know what's going on, but let me test his genetics, and they found XYY. The multiple psychiatric hospitalizations before that probably should have triggered someone else to test him at some point, and so, I'm glad he was identified, but it was really sad that it took that much before someone kind of figured out that there's probably a, component of his problems that are related to the XYY from a mental health perspective. There's a lot of mental health problems in the family as well, but, I think that it definitely was impacted. So, in our study, 34% had tremor. Most of the time it started later. So it didn't start in the early, 2 to 3 years of age, but it started 8 or 9 years of age, and then increased as they went on. And most of the time it's an intention tremor of the hand, so when they're resting, you don't see it. But when they go to do something, you see it. So it can impact them more if it gets more significant with drinking, with eating, with writing, with buttoning, when they're intending to do something. And usually at rest, you don't see them do any shaking.
Can I ask you a question about that? I read somewhere that as they get to be an adult, they control it more. Is that true or no?
That's not what I've seen. I've seen it actually get, if anything, it can get a little worse. Now, it doesn't, continue to get worse. But, when it starts, I see it progress through adolescence. This is actually our data on it, is the percentage of boys who had tremor as they went up in their age. And you can see it just went up. There were a couple who were 4 or 5 when you saw a little bit. And then as you went up in age, the percentage who had it got that. Now, sometimes it's still mild, and sometimes it just starts and then that's all they have. So we don't know what makes it worse or better, or,
So OT and would OT help, or?
OTs usually notice it, and I don't know that OT helps it.
Okay.
Are there meds?
There's meds that can help it if it's bad. They're not usually meds that, if they have a little tremor, again, I wouldn't start it just for that.
Yeah.
But if it's impacting their writing, if it, we had one boy who was a waiter, and he was having a hard time putting the food down, and so, it's impacting them in day-to-day life. They can't button if they're having a hard time eating. There's also some other things that can help tremor, like there's weighted silverware. So if they are having a hard time eating, you can get them kind of more weighted silverware, and that seems to help it. So there's other accommodations. I always recommend, for anyone who has tremor, and I think this is just a good kind of medical leeway or medical trick to use also, but getting them involved in keyboarding in school. I always think it's good for them to have keyboarding too, but if you say, well, he has tremor related to XYY, and we really have to get him a keyboard and an AlphaSmart or a laptop, then it helps them get that too, because there's a medical reason instead of just some parent requesting, that they have some help with that. So I use the tremor a lot to help them get some other accommodations too. In seizures, we had 12% of our group had seizures. Does anyone in here have any seizure problems? So 12, seizures in kids are definitely not 12% of all kids have seizures, but 2 to 3% have some kind of seizure problems at some sort of time in their life. Sometimes it's more febrile seizures when they're younger, but seizure disorders are not uncommon in the general population, but this is higher. And so, if there's any concern, most of the time they were seizures you would notice. So, a generalized tonic-clonic seizure is not something that parents generally don't have. Yes, Carol? I thought you were raising your hand. But some of them have had these staring spells or kind of petite mal seizures, and that can be more subtle. This was rarer, but it's still important that if there's like a clear staring off, kind of doing something and then coming back, that can be a seizure. It's not just that they're just staring off. A lot of parents will complain, yeah, he stares off, he blanks out. So how do you differentiate those? Well, is it when he's just watching TV and he's like this? That's not a seizure. But if you're seeing him kind of actively doing something, and then he stops for a few seconds and kind of either looks up, and most of the time you see eyes deviate, you see their mouth moving a little bit, and then they come back and they don't seem to remember, or they seem to just pick up as if something else wasn't happening. But they don't usually occur just in one setting. Well, yeah, he always stares off when he does his homework. Well, that's very good. Like his homework.
Is there a
really where we start to see them. However, sometimes those absence seizures can be missed for quite a while. And so, you know, if there are happening any kind of funny spells that you're like, huh. The best thing to do also with that is instead of running out to get the whole EEG and workup, is if you can predict them or capture them in any way on a video, then it can be really helpful to show someone who can just look at it and say, you know, that's not an absence seizure.
But aren't they hard? I mean, Brandon, we got a call from the school because he had been doing, there was like this week period where they were noticing him and he kind of jumped, like he'd go like this and he wouldn't respond and then he'd jump and come back. We did all the testing, 24 hours, take home, and you know, nothing showed up. So my understanding is that it's possible that they're still having seizures, you just didn't capture them during the testing.
Yeah, correct. So some of them, if they are, you know, if you're seeing true spells where people are concerned, then that's definitely something you want to have further evaluated. Sometimes you need a, you know, 48-hour EEG. Sometimes you need a 72-hour. So, I mean, so I think it's important to try and capture them, especially if there's something like that. Yeah.
Well, the neurologists often call them negative when they're really subtle, unless you do have a sleep EEG or overnight.
Sometimes if they read, so for these types of seizures, the best evaluation, the ones they'll start with, is a regular EEG. That means that they'll tell you to come in sleep deprived, but half the time your kids never really fall asleep because you get different brain waves and you're more likely to see seizure activity during sleep. You know, it can capture it a lot better. So oftentimes what happens is you get this really short 15-minute EEG. There isn't anything funny that's there. They don't really fall asleep, and then they say this is a normal EEG. If you still have concerns, like, well, he's still having these spells, or there's still, you know, clear episodes, well, then you want to go to a more prolonged EEG and try and capture one of the episodes on the EEG. And usually what they do now is what are called ambulatory EEGs. So they'll put all the stuff on, and then they'll send you home. And then even sometimes they'll do video EEGs. They keep you in the hospital and videotape you with the EEG on. So there's different levels of progression. And so, you know, if you're really concerned about spells or, you know, other things that are still happening, the thing is they shouldn't go away. So, you know, if they've had one or two, and then you've never seen it again, well then it's probably not a seizure. Or it's not a seizure that you're going to treat now, you know. So, you know, there's different steps in terms of how to evaluate it.
I don't know, this just reminded me of something Tyler just started doing. He'll be eating, and I just saw it happen the other day where all of a sudden he panicked, and I said, what's the matter? He says, I forget how to swallow. And he's mentioned that before, but he thinks he's choking because he gets the food and then he can't get it the rest of the way. And so when I was eating with him the other day and he did it, I started to react because he kind of freaked like he was choking. And then he went, oh, okay. I said, what was that about? And he said, I forgot again how to swallow. And then that reminded me, I'd heard him say that before. And I said, well, how long has this been going on, Tyler? And he goes, I don't know, maybe a year. And so I don't know, have you ever heard anything like that before?
Yeah, I mean, not in XYY, but I mean, that's definitely important in terms of there can be what are called esophageal spasms, where their esophagus can kind of spasm, and that can sometimes lead to food getting stuck. There can be different kind of neuromuscular problems in how your food is being swallowed. And so it's not like he's forgetting how to swallow, but it's getting stuck there, and then, you know, and then his esophagus relaxes. So if you're seeing it often, that would be an indication for what's called a feeding study or a swallow study, where they actually watch the movement as it goes down.
Gastroenterologist?
And just making sure.
Because
Because I mean, kids don't forget how to swallow. I mean, even in XYY, they don't forget that.
Well, what do they do about it? I mean, could he?
Well, there's medications that you can use if it really is spasming to help relax it.
That can be a brain thing? Like,
It could be also. Yeah. Well, it would be a more dangerous brain thing, something changing. Because, I mean, his brain not telling his esophagus how to work, that's a very primitive kind of mechanism. So if you're seeing that, and, you know, you want a good visit that someone's going to do neurologic evaluation. But I would be more worried about some of the, if it's just that and you're not
Start
seeing
with a
it.
gastro and see if he sees a spasm, and if he doesn't, doesn't see a spasm, that's when you would advance. to-
Yeah, you might start, yeah, I would start with the gastroenterologist and see what they think, and if they think any further neurological evaluation needs to be done.
Okay.
You know, it's interesting how he's describing it.
Yeah.
Yeah, and just this talk about this just reminded me, and I'm glad, because I looked it up.
Because, you know, I mean, that's not something you forget.
Is he?
I wish I could forget that.
So- Good diet.
What, Rebecca?
Is he panicking?
Yeah, he panics because he
And
can't.
he's not, there's not an over like he's getting anxious and then.
No. It was like just the other day we were out, my son, we were out having fun. We were having lunch and all of a sudden he panics because he can't breathe because
And is
he,
it certain kinds of foods like
No.
this, and he's not stopping?
no, he just said it just, he describes it as he forgets to
Yeah,
stop.
but all those things are important things. I mean, they'll evaluate if it's liquid versus solid versus solid.
Okay.
So then we're talking about low motor tone and coordination. So low muscle tone is something that's very commonly described with XYY. Tone in the muscles, you know, we, in the lay press and, you know, kind of layman's terms, we consider tone being toned and fit and strong. But tone actually means that it's the resting resistance in the muscles. And so you can have normal strength and normal muscle bulk, but still low muscle tone. And tone, if you're low tone, you tend to be floppier. And if you're higher tone, you tend to be stiffer in your movement. And so people who have had a stroke have high tone, and people who have, you know, low tone tend to be floppier. So I think it's important from a medical perspective when we talk about tone, and when your physical therapist and OTs talk about tone, they're talking about this resistance. And so when you have low tone, things are harder to do. You're moving your muscles against more, you have to kind of use more force to think. So so we think this is part of the reason why they tend to be more easily fatigued, why they lean on things all the time, while they're always sitting or slouching, why it's harder, because they just have more to kind of work against. It might be the reason for some of the constipation problems that we see sometimes, because you need tone in your muscles to be able to, you know, push out that stool and other things, and it might lead to lower tone in the intestines as well. And so, you know, we think this is related to a lot of different things. And also the motor delays that we see sometimes.
Does it not have anything to do with the, like, I mean, isn't the lack of toneness an indicator of low tone?
You mean the lack of definition, an indicator of low tone?
What?
Lack of definition, an indicator of low tone?
Yeah.
Sometimes a little bit. But it's not always, they're not the same thing from a medical perspective. So like boys with XYY, their actual muscle volume, like the bulk of their muscles, is not necessarily lower than a typical XY boy.
So when you.
But it's just more their muscles are not as, they're floppier. So they're not quite as bulked up, like they're not boom.
So that if they lifted weights and they did exercises.
It might help their bulk, but it also does not necessarily help your tone just to do exercises. So some kids, you know, physical therapy helps, occupational therapy helps, but it doesn't help everything. It won't fix everything. There's still a, you know, decrease, like tone it comes from your brain sending signals to your muscles to keep a certain number of your muscle fibers contracted. And when you have, when you have a stroke, that signal is not the same, and so it keeps more contracted. And then when you have, so that's why you see differences in the stroke from one side to the other. And if you have low tone, then your brain is not connecting to your muscles as well to keep that certain amount of resistance in there.
So it's not a strength issue, or it is?
It's not always a strength issue. You guys will see, sometimes these kids can kick and fight and and you pick them up and it doesn't correlate with strength. You have strength and now sometimes you can also have weakness. Weakness is strength, and so you can see these guys also have more weakness relative to the other kids. But tone, from a pure neurological perspective, they're separate. They definitely interact with each other.
Right.
So this is in the literature a lot of times. Our study, 44% had low tone. It tends to be more prominent when they're younger, get better as they get older, but not always. Some adults still tend to be floppier and have lower tone and more problems.
Well, low tone, did it have anything to do with how they use the muscle? Like if they were to throw a ball or something like that, they just don't have a good fluid motion at a normal tone?
Sometimes, but that also can be related to what we call kind of praxis, which is, and coordination, which is how they actually, their brain tells their arm and their joints and their muscles to move in the room. So there's a lot of different things that go into motor movements. Muscle tone being one, strength being one, motor planning and praxis being another one. And all of those tend to be impacted in XYY. So the throwing piece can be related also to them having difficulty figuring out, okay, I have to get the ball, put my arm back here, put it here, release. That's a lot of different steps. And we know that dyspraxia, or problems with that motor planning, is a component of XYY and the other disorders, the other XYY disorders. And so these were the things, so this was a formal study, and actually the OT who was here, who did the session in the morning, is doing some more formal studies on XYY. But we don't have very many formal studies. This was 4 guys in 1987. But he saw lower muscle tone, motor planning dysfunction or dyspraxia, problems with bilateral coordination, and then problems with visual motor integration, kind of knowing what to do when you see something and that motor piece with that. So, these were the areas where there's weaknesses, and this is what we see in the clinic and what your OTs will tell you also. We did do a study where we had 24 patients, and we saw that 67% had motor coordination scales in the delayed range when we actually did testing on them too, in our study with the mind. And so, not every boy had a lot of motor coordination planning problems, but 67% did. And so the recommendations in here are OT and PT, and then also keyboarding and assistive technology if they have a lot of fine motor problems. So the other thing I'd like to move on to now is puberty, testosterone, fertility. Parents have a lot of questions about this often. You're at a conference where it's very highly dominated by XXY families. There's a lot of talk about testosterone and fertility and other things. And in general, what you guys need to know is that you don't need to worry about that stuff. So XYY is not the same as XXY. And so most cases have normal puberty. They don't have problems with fertility. Okay? That's just in general. However, it's important to know a few things. The testosterone levels in XYY, people will ask you this. Well, does that mean they're higher than other kids? And no, they're not. When people do studies, they're normal. They're not too high, they're not too low, they have normal testosterone. So I think for your own information, that's important for you guys to be able to respond to people because they're going to ask you those questions. I have seen a couple males with XYY, and there are a few cases in the literature as well, that do have low testosterone levels. So again, in most cases, this is not going to be an issue, but it's important because you're at slightly higher risk of having some testosterone problems than kind of the general population. And so hypogonadism is the term we use for low testosterone production. The clinical signs that we see in that are fatigue and poor endurance, which we can see in XYY anyway. This would be different than if this occurs, this is going to show up in adolescence or young adulthood or later adulthood. And so what you're going to see is that you're going to see there's a change from before. It's like as if you developed hypothyroidism or low thyroid. You were going like this and then there's a change. So if they've always had fatigue and poor endurance, it doesn't mean their testosterone is low. Low body hair or decreased sexual development or decreased sexual functioning. So, they had some normal sexual development for a while. It doesn't seem like their beard is this thick. They're not having erections like they used to. You might not know some of these things about your teenagers, but, this is important that maybe, you're seeing differences in some of the other things. The penis is smaller, the testicles are smaller. So this is just important to know that it can be associated and to think about it if you see changes, especially in later adolescence or adulthood. If they're concerned, they can be evaluated by an endocrinologist. You do blood level checks. You just make sure that things are normal. If they're not, they would replace testosterone. You probably, for these types of things too, you'd want to do thyroid testing. So if you're seeing those types of changes, it's important to know. Fertility is generally normal. So the questions that come up are there extra Ys in the sperm? And in general, there's not. So the sperm corrects itself, kicks out the extra Y in the majority of cases. However, they're at slightly increased risk of having extra X's and Y's in their sperm. So it's important to know that when they do decide to start to have kids, that they go see a genetic counselor and talk about the risks. There are families reported in the literature, dad with XYY, son with XYY. And so those are just important things to know. The fertility in XXY, or Klinefelter syndrome, the other group that's here, is almost universal that they have fertility problems. In XYY, it's almost universal that they don't. However, their risk of having fertility problems is also higher than in the general population. And so when you look at surveys, like they surveyed 1,000 males who had infertility, and they found 3 who had XYY and 28 who had XXY. So the result in these studies where they look at men presenting with infertility, they always find a handful, a couple who have XYY. So this is important. We would expect with the rate of XYY, if you just sampled all men, this would be 0.1%. So it's always a little bit higher than you would expect just based on the general population. And when they do those testing on those guys, sometimes with the extra Y, there's an extra piece of the extra Y, or there's little small deletions in the Ys, and so they find other kind of genetic differences that on further evaluation they didn't find on the further karyotype. So they're slightly at higher risk for XY variations in their sperm. They're at slightly higher risk for kids who have XXY or XYY based on the way the sperm develop. This is rare, so we need to do some genetic counseling before they decide to have kids, just to discuss those risks so they're aware.
What age would you suggest that genetic counseling?
13.
So and Susan told us September.
I'm just kidding. It depends on the kid. I mean, some kids are not at all, you can't even imagine them talking to a girl, right? And so, if you can't imagine them talking to a girl when they're 13, they're not going to be going out. But if they have more normal, more typical development, and they're, then, most of the time we recommend they go to genetic counseling when they're planning on having kids. Some parents will do it as like the scare factor to, okay, well, if you're sexually active now, we want you to know and go and talk about your risks. And then they kind of freeze them out.
Cell phone and computer bills.
Oh, really?
So maybe we should see.
So, yeah, usually, what do you think, Susan? Usually it's more when they're planning on having kids. Yeah. Like when it's an intentional,
Because you want them to be able to remember the information too, and not be like, I can't believe we're having this conversation.
Yeah. This is to to help them and their wives decide on, what they, if they want to have a lot of prenatal testing, if they care about this increased risk at all. Some families would choose, different methods of reproductive testing or prenatal testing if they think there's a risk, and so on. Okay, so these are some of the other medical problems we sometimes see. Strabismus or lazy eye in 15%. This is higher than the general population, so I think it's associated with XYY. More significant dental problems, needing lots of dental surgeries or odontia, lots of cavities, allergies and asthma. Typically when these kids come in, if it's a new patient, they're on their asthma meds, their allergy meds, and their ADHD meds. And that's what they present on. And so, so it's more, everyone, allergies and asthma are not uncommon. The treatment in XYY is not different than you would do typically, but this is showing up way more than you see in the general pediatric practice. And way more than you expect for family histories. A lot of time, he's the only one with asthma in the family. He has the worst allergies of anyone, A few people have a little hay fever, and he's got really bad allergies. So I don't know if it's immune. I don't know why. I'd love to have some asthma and people interested in why this is occurring so much. It's not usually debilitating. Most of the time it's an inhaler. It gets better as they get older, like typical asthma. But there's more kids that should have asthma with XYY. Being hospitalized for pneumonia, the same thing. There's just more hospitalizations than I would see in the general pediatric practice. Having a hernia repair. Did any of the kids in here have hernia repairs? So this was surprising at our conference because this happens a lot in XXY as well, and XXYY, and we anticipated it was related to testosterone deficiency when they were younger. But the same percentage showed up across all 3 groups. So even the ones that we know are associated with testosterone deficiency, we know testosterone is important in helping the testicles descend. And so I was expecting this to be much lower in XYY, but it's not. And so it might be a different mechanism that's involved. And then sleep apnea and constipation. Here's a little guy who's beautiful, however, showing his strabismus. eyes are aligned. Okay, and so these are medications in the survey. When kids came in, not even the ones I started on medication, because for some of you who know me, I do think medications are an important part of a lot of behavioral and emotional treatments. But these are kids who just showed up. So before even I got my hands on them, how they were showing up to clinic. And so I wanted to survey you guys to think which category you thought was going to be most common, whether they were on no medication, asthma, allergy, seizure meds, ADHD meds, or other psychiatric medication. Other psychiatric meds. And you're right, both of you, all of you. So, 24% showed up on no medications, 29% had allergy and asthma medications, 10% on seizure meds, and then 41% on ADHD meds, and then 49% on other psychiatric medications. If they were on other medications, it was either SSRIs, which are the serotonin medications, which are used Prozac and Zoloft, and those classes of medications for anxiety or depression, or other mood stabilizers or atypical antipsychotics, Risperdal, Depakote, Abilify, those types of meds. And then 37% were on more than one medication.
The SSRIs are what's used to treat anxiety. And what about OCD? Do you see a lot of those types of?
We do. It's not always like strong, really strong, but there can definitely be some obsessive compulsive behaviors in a subset of the kids.
And so is that?
And that's the same. That's these.
SSRI?
Yeah, that's these. If they tolerate these. In XYY there tends to be a higher rate of this kind of moodiness and mood instability and, behavioral dysregulation. And SSRIs can be what are called activating. Or in some kids they can cause you to be a little more irritable. And so, not always, and so I use these because the side effects are much less than here, but it's not unusual to have a kind of activating or more agitation when you see the SSRIs. In which case for OCD, some of the atypicals can be helpful, that have some serotonin effects also. I'm giving a whole talk on medications, and so I'm happy to give, you guys can ask more questions there. That usually comes up a lot. So these are kind of my recommendations. What should you guys be looking for at different ages? What kind of things should you be watching for? So between birth and age 3, obviously developmental delays are one of the biggest pieces that I think are important in their muscle tone. But the vision in strabismus needs to be corrected early if it's there, because your brain and your vision depends on that.
What do you call early? I mean, my son's 13 now.
Yeah.
Is it too late for him?
Well, has he seen an ophthalmologist?
Well, he saw one who recommended vision therapy, and we just were unable to do it at the time. That was like 2 years ago.
But like tracking therapy? So vision therapy I don't think is necessary.
Seemed double, but
Yeah.
that's gone away.
Yeah.
But she recommended vision therapy, and, very costly, insurance didn't cover it, that kind of thing, we just weren't able.
So I also don't usually recommend vision therapy. There's not a lot of science around tracking therapies or anything else. The therapies I recommend are patching if needed. Usually by that age, your brain, your visual cortex has developed, and so you don't do the patching as much, but there still can be surgeries and other things you do. And so I would make sure you don't go to an optometrist, but you go to an ophthalmologist who's a medical doctor, and they can tell you if there's anything else they need to do.
Did you know NIH has done a study on vision therapy?
Yeah, and what?
My understanding is that they're starting to see that it is helpful. And I mean, like, we had our daughter who was having reading problems with vision therapy, and it was life-changing for her. So, and my younger one is reading from right to left rather than left to right. So, I know there's controversy in the field, but it sounds like there's starting to be more science behind it.
Good. We need more science behind it. Who it works for, who it doesn't, who to refer, because just reading therapy, for anyone with reading problems, I don't think, that's not the first step. The first strabismus for true, malalignment of the eyes that you can see, doing tracking therapy and strengthening exercises are not, that's not the answer. You need to go see a doctor who's going to help you figure out exactly if they need drops or surgery or other things. So, respiratory infections, asthma, allergies, again, there's no big differences in the treatments that you would do for these, but just knowing it's more like, that's why they're having more infections than the other kids is probably helpful. Looking for inguinal hernia in case there are any bulges or anything down there. constipation treatment, flat feet treatment, as we talked about, dental development, making sure they're getting good dental care, because you might struggle with that all along the way.
Can I ask a quick question about the infections? One of the things we've noticed with Brandon is that he doesn't get very sick very often, but when he does, he gets really sick. And so I'm wondering if you have any ideas about how to, I mean, is it just a matter of getting on stronger antibiotics at the beginning, or like what would help?
It depends, you know, if he's not getting sick very often, but then he gets sick, you know, you just want to make sure you're going in as soon as you can, and you're with a pediatrician who recognizes the severity of each illness and doesn't try and start with like the lowest dose of antibiotic at the beginning and trusts you. You know, so it's more like if I had a patient like that, as soon as mom called, I would know to be like, okay, get in, or here, let me just call you in the script, or something else, you know, let me see him right away, instead of, well, you know, waiting for this. Is he doing this? Is he having fevers yet? Is he, you know, you treat that a little bit differently. Otherwise, there's no, you know, if he's getting sick very, very, very often, then there are some immune deficiencies you look for. But if it's just, you know, every once in a while when he does get sick, then you just want to make sure you have a good relationship with your doctor who will be aggressive to help, you know, hold anything off. So then developmental delays, learning, behavioral, emotional, social problems between 4 and 12, motor coordination and tone, asthma and allergies again, so tremors and tics, this is when these are going to show up between ages of 4 and 12, you know, continuing with the dental care. Sleep apnea is important because we've seen it in the population of these kids, especially as they get bigger, and it definitely can impact daytime behaviors. And so sleep apnea symptoms are, you know, either snoring or irregular breathing during sleep. You know, you hear them kind of gasping or choking, or they just don't have a regular breathing pattern. Having a hard time waking up in the morning, having a short sleep latency during the day. They're the kids who always fall asleep in the car, always fall asleep watching TV. They, you know, fall asleep right away at night, sometimes waking up with headaches. Those are all symptoms of sleep apnea and important to know about because it can impact behavior, but it can also impact heart health and other things as well.
And then, question about that.
Yeah.
Is that does increase as they get older? Because like Kyle never had trouble sleeping, and now he has to go to bed with ice on his head. He sleepwalks. And we're trying to figure out if it's like medication or it's just something that has to do with.
So sleepwalking isn't usually related, but nighttime awakening and differences in that sleep cycle, it's definitely something that you don't see in you can see in 5-year-olds. But this is as they're getting bigger and their muscle tone is still low, and sometimes they're, you know, gaining weight and other things, and that can definitely increase it. So, you know, and if you're seeing some of those daytime symptoms too, it might be worthwhile to see someone about it.
Okay.
What medication is he on?
Concerta.
Okay.
And clonidine, they just started on clonidine.
Yeah. So you can see if the clonidine helps with the sleep. Concerta usually can sometimes disrupt sleep cycles. Clonidine usually helps with sleep.
That's what I mean.
Yeah. So,
And it seems like he's becoming addicted to the clonidine too.
like he needs it to be able to fall asleep.
Yeah.
You might, we can talk at the medication talk a little bit, but you might re-look at, you know, the dose of Concerta, and if there's different medications, different ways to administer it so that he's not having the sleep problems at night as much, and then you don't need the sleep medication, you know, you don't need the clonidine to help with it.
So who would you see if you suspect sleep apnea?
You know, most people would say to start with your primary care doctor because every community is a little different on who they refer to. Some refer to pulmonologists, some refer to ENT, some refer to sleep clinics. And so I would add, you know, it's different depending on the different communities, kind of who does the sleep apnea.
Okay.
There's one other thing that helped Tyler was they removed his adenoids.
Yeah, and some kids when they're younger, the treatment, all it is tonsillectomy and adenoid. And so, because that opens up the
Totally
area.
helped.
So this is it before lunch, right? So you guys want to keep going, or you want to go to lunch, or anyone can feel free to leave if they want to, because we're supposed to end about 5 minutes ago, but we got to start this a little late. We don't have that much more to do. We're not going to talk about all of these things right here, but I think these are all the things in terms of, you know, we talk about all the difficulties, and they're really at risk for a lot of different things, and so there's so many overlaps between the way they all overlap. Not everybody has all of these different problems. Some of them have more significant problems in some areas than others, but these are the problems in XYY that parents bring up with us. are, the developmental delays, the learning difficulties, usually more in verbal and reading, but sometimes more global. The short attention span or ADHD and impulsivity symptoms, social skills difficulties and autism spectrum disorders, sensory integration problems, and then anxiety, depression, and mood problems. So, you guys have all probably heard this terminology before, but it's overwhelming, I think, for some parents when they see this list. But then, a lot of times they can identify some of the difficulties.
Are you gonna talk more about some of those in the medication talk?
We're going to talk a lot about medication treatments and some of those in the medication talks, and we have a whole separate talk on ADHD and medications and treatments for that. So those two talks will cover those issues. This is just about kind of what we're seeing in our population from XYY. So, we always compare what you see in the prenatal group to what we see in the postnatal group, because what the counselors and genetic counselors want to know, and parents who are diagnosed prenatally want to know is, well, what are my risks for these problems? And we do know there's a difference between whether or not they're diagnosed before birth and whether or not they're diagnosed after birth for a problem, like I was talking about. So, we see that the IQ, in general, 85% even in the postnatal group have a normal IQ. They don't have IQs that are in the intellectual disability or mental retardation range. But 15% of them do. And then those are the mean full-scale IQ. So an average IQ is 100. So in our prenatal group, our average IQ is right where it should be. In our postnatal group, it was 88. So it was lower, but still that's in what we would consider the average range. 47% versus 77% had some kind of special education support in school. Speech therapy was 53% versus 77%. Motor therapy was about the same in both, about 60%. The diagnosis of having PDD or autism spectrum disorder was 20% versus 38%. This is important because even in the prenatal group, we're seeing some of this, So it's not just the kids that are more affected. I mean, some of these, and then the rates of ADHD weren't really significantly different between the two groups. So this is the normal curve, and so I think it's always important to kind of, I like looking at this because this you could use a normal curve for anything, for height, for IQ, there's an average or a 50th percentile, and when we talk about IQ, that average is 100. But there's always, and most kids, are right there around the average range. And then, the curve goes out, there's, fewer and fewer kids who are lower and lower, and fewer kids who are higher and higher. But generally, we look 2 standard deviations, or the third, so these are usually, when we consider what's normal, is are they within 2 standard deviations of the normal. And so, anywhere from 70 to 130 is considered the normal range, and then the 50th percentile, the average is here about 100. So when we look at XYY, this is the comparison of what the IQ scores were in those studies that included the Denver study and the Toronto study and all those studies where they followed the kids all through life. And basically what they found was that in XYY, it was just shifted down a little bit. And so, there was many more kids who overlapped with what was normal. This is the XYY curve here. However, their mean scores were a little lower. And, if you look at that then and you draw a line at the percentage of kids who are going to be below 70 or have an intellectual disability or more significant problem, you're going to see a higher percentage of kids down here than you would see in the general population. And so I think this isn't just, it helps to also see that there's still a lot of kids and people who are up here and who are functioning at a high. So, I think we're probably missing a lot of these patients. These are the ones that we're not diagnosing. We're tending to see, you can still see educational problems, learning disabilities, and other things in this range. So we're tending to find more of the kids with XYY who are over here. But I'd like to show that because I think it's important to show with everything it's a spectrum. And with some traits, your kids are going to be up here, with other traits are going to be lower. But in general with XYY, they tend to struggle a little bit more in some of the areas. These are the behavioral profiles. So this I actually didn't get a chance to update from last year, but this is parents filling out about behavioral problems in their kids. And these are 31 parents with XYY between the ages of 5 and 21. And so basically on this, the average score is 50. Between 50 and 60 is considered the normal range. Between 40 and 60. And then above 60 is what's considered the average range. This is an average, so some of the kids were down here, some of the kids were higher. But in general, we saw concerns or elevated scores more in the areas of hyperactivity and attention span, and then atypicality, which is some of this atypical social behavior in XYY. What we did see, and what I was really glad to see, was, their actual aggression scores were not even, were in the normal range. And I really like that finding because with all the literature about XYY being aggressive, this actually showed that you guys in general didn't think they weren't aggressive. And we don't see a lot of, it's not that we don't see physically aggressive acts, but we don't see malicious physical aggression. If we see aggression in XYY, it's often very reactive. They're reacting to being threatened. They're reacting to someone trying to force them to do something in a certain way, and then they can act out. But we don't see a lot of, them going around trying to hit and beat people up. They're not the bullies. They're being bullied, if anything. Or they're those reactive bullies. They're bullying as a protective mechanism because otherwise, they're threatened. And then adaptability and social skills were lower. These ones are concerningly they're low. So they had a harder time with some adaptations and changes, and then socially they had a more difficult time. And then this is autism and autism spectrum disorders, and we're not going to talk about this that much, but in general, we found that autism spectrum disorders were higher in kids with XYY compared to the general population. And so this is a study that we did between the 3 groups of boys. XYY is the group in the middle, and what we found was this one is no, this one is no autism spectrum disorder. This is autism spectrum or PDD, a mild form of autism, and this is autistic disorder. And so we found that, as you added more Ys, that you ended up having more autistic features. However, in XYY, it was more PDD or mild autistic features, and usually not full autistic disorder. And then, we're not going to talk about ADHD because we have a whole talk on it. There's a very cute little boy with XYY. This is our clinic that some of you guys have been to, that's in Denver. We call it the Extraordinary Kids Clinic. And, we don't have all the people in it. Anyway, so our clinic is, it has 2 psychologists, a neuropsychologist who does more assessment of learning disabilities and executive function, and then Rebecca Wilson, who's here, who's our other child psychologist who does do learning and evaluations, developmental evaluations, and emphasizes a lot of the social and emotional difficulties. We have a speech therapist, we have an occupational therapist, and then we have myself, we have an endocrinologist if they're needed. So the kids come and see whoever they need to see from that team. Some see everybody, some see just me, some see just someone else, usually someone else and me. And so if anyone has any questions, our genetic counselor and our clinic coordinator is here, Susan Howell. We have information here about our clinic, and so we're happy to talk with you guys more about it.